You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 28th, 2025. We are doing our orientation series, and today's topic is drug allergy. This is presented by Dr. Pandya, who's an associate professor of pediatrics and is the medical director of the Food Allergy Center at Children's Mercy Hospital in Kansas City.
We're going to do drug allergy. I will reintroduce myself. I'm Pandya. I am assistant professor of pediatrics here at Children's Mercy Hospital, as well as the University of Missouri, Kansas City, medical director of food allergy, and we are going to be talking about drug allergy today. These are the relevant disclosures for today's talk. So we're just going to go right into it. The objectives of today's talk are going to be to understand the drug allergy, different mechanisms, different classification systems to diagnose drug allergy, as well as the management of drug allergy. How do we classify adverse drug reactions? So I think the way that we start first and foremost is seeing if the patient has symptoms and signs that are consistent with a type A or a type B adverse drug reaction. So type A is predictable pharmacologic effect that occurs with a medication. These are very common. An example of this would be diarrhea with antibiotics. And so this is not dependent on the individual's immune response, having an effect with the medication. Type B type B adverse drug reactions are what we consider our hypersensitivity reactions. So this is an individual's immunologic or inflammatory effect on a medication that results in the clinical outcomes with a medication. So assuming that we are having a kind of hypersensitivity reaction to a medication, there's various different ones that we are going to hit on a talk. But you can see with this particular chart that comes from our drug allergy practice parameters, the importance of delineating timing from onset of medication to inciting, the actual reaction. So I'll give you an example of this. So for instance, IgE-mediated can be less than 6 hours with oral medications. You can have non-IgE-mediated mast cell activation that happens in that same time frame, if not a little bit sooner and also a little bit more delayed. Let's talk then about contrasting that with serum sickness-like reactions. Well, that can occur a little bit later. That can occur within the week, but it's generally not going to occur beyond the second week past the medication being administered. And you can see how that differs with things like drug-induced lung injury or DRESS syndrome or SJS-TEN. So I think this is an important point for us to consider. This will also affect how you take your history for drug allergy patients. Further classification can be delineated into immediate reactions. So this is generally considered to occur within 1 hour of a medication. So this is assuming that the medication is administered by the oral route. With parenteral administration, the reaction can potentially happen sooner. In some cases, with oral administration of medications, it can be up to 6 hours after the drug was given. And then delayed reactions evolve over days to a week after exposure of the medication. So you can also say that this was an immediate reaction or a delayed reaction. In terms of our different on-target and off-target adverse drug reactions. So this can be, delineated further based on this chart here. So like an on-target ADR, again, analogous to like your type A reactions that we were talking about here, is the predictable based on the drug action. So warfarin bleeding, antibiotic-associated diarrhea is kind of another one that we talked about. Your off-target one is really where you can have interaction with an off-target receptor, which can be dose-dependent. Here we have MRGPRX2, which is listed as an example. Or we could have a drug allergy with immunologic memory. Again, largely we're talking about our Jelen-Coombs hypersensitivity chart when we were looking at these. You can have pure T-cell mediated responses. Again, we're talking now more about purely type 4 reactions, or you can have antibody mediated mechanisms that are dose independent. And then potentially your T-cell mediated responses could be dose dependent here. All right, everyone's favorite chart that we learned first in med school and that we have carried through with us into our clinical practice is the Jelen-Coombs hypersensitivity classification system. So here we, of course, have our major for hypersensitivity reactions. These are listed as type 1 through 4. And then within type 4, we have 4 different subtypes here. So let's go through these. So in terms of your immune reactant here, with type 1, this is largely an IgE-mediated mechanism. Again, we have a specific IgE binding here with our IgE receptors. We have cross-linking that occurs. We have mast cell activation and release of mediators. Type 2 can be IgG or it can be IgM, antibody dependent. And here we are going to have 2 mechanisms at play. We are going to have potentially complement activation and effects of complement activation that result in your clinical picture that occurs. Or you can have some antibody-dependent cell cytotoxicity that contributes to that reaction. However, you have effector cells that are also playing a role here, perpetuating the reaction too. Then type 3 is going to be largely IgG complex mediated. So here we have immune complexes that deposit into various different places. One example here could be the blood vessels. It could also be the interstitium of different organs here, and then subsequently you develop hypersensitivity reactions through involvement of complement or other effector cells. And then type 4, again, we have 4 different types here. Type 4A is largely going to be with Th1 helper cells. Type 2B is going to be with Th2 cells. Type 4C is largely going to be with cytotoxic T cells. And then type 4D utilizes your different cells here with neutrophils to continue your reaction. You can see here that the effector cells vary dependent on the type 4 reaction, and we can see various different ones listed here at the bottom, including Dress syndrome, SJST, and bullous exanthema, etc. Okay. Immediate reactions, so this is attributable to the vasoactive mediators released by mast cells, basophils. The most common signs and symptoms when it pertains to drug allergy reactions include urticaria, angioedema, pruritus, flushing, and then, of course, respiratory involvement, gastrointestinal involvement, or cardiovascular involvement. Time of onset is influenced by route of administration. So intravenous medications, this can take seconds to minutes to occur. In terms of oral medications, this can be within minutes. One factor that changes this depends on whether we have an empty stomach or not. And then 10 to 60 minutes if taken with a food. In terms of the likelihood, in terms of timing of onset. So the timing of onset does play a role into when the bulk of the reactions happen. 60 minutes is when the bulk of immediate reactions are going to happen with medications. You can see now why we do a 60-minute observation with regards to many patients that we do drug challenges on. However, it can be delayed, as I mentioned in an earlier slide. It can take up to 6 hours to have a immediate reaction. So it's one thing to take into account here. But again, the bulk is going to occur within the first 60 minutes. IgE-mediated reactions generally require previous exposure to the drug in question. The question here is, how are we getting exposed to the various antigens, haptens that are in these medications? Are we getting exposed prior to, oral administration of the medication is one question that's, thrown out there in our research setting. And it is important to remember that point, though, when you are taking a drug allergy history, especially dependent on the consistency of symptoms as it pertains to immediate reactions. Absence of known or prior exposure doesn't exclude an IgE. That's kind of the point I was getting at here. Sensitization can have occurred through a cross-reactive component. We're not really sure how that happens, but we do know, meaning we don't know how that happens in an individual person, but it is a known phenomenon that can happen. And so you don't want to use that particular point as a complete exclusion. Commonly implicated drugs. So for IgE-mediated reactions, beta-lactam drugs are one of the most commonly implicated. Then we have neuromuscular blocking agents, we have quinolones, we have platinum-containing chemotherapeutics, we have foreign proteins like chimeric antibodies like rituximab and cetuximab that are implicated as well. We are going to dive further into penicillin and beta-lactam allergy, again, following mostly talking about immediate reactions and then maybe some delayed reaction discussion here as well. So within penicillin allergy, beta-lactam allergy, immediate reactions can occur. The allergens do include the beta-lactam core, so penicilloyl minor determinants as an example, penicilloate, penyloate, or you can have side chains. So the side chains can have cross-reactivity with cephalosporins as well, so it's an important point to note. Versus you can have delayed reactions, which the vast majority here are going to be benign cutaneous reactions, which are generally non-reproducible, and that can also be a confounding variable with underlying illness when those medicines are administered. But of course, you can also have scars or severe cutaneous adverse reactions that can result from penicillin antibiotics as well. So the penicillin allergy label, patients frequently get labeled with penicillin allergy. The reaction can vary and include family history, headache, nausea, loose stools, or I've never taken the medication. So if any of those factors are here, you can potentially delabel without even testing is an important point to note here. And then more than 95% of patients labeled as penicillin allergic will have negative testing and subsequently tolerate the exposure. So delabeling is an important measure that we can take as part of global antimicrobial stewardship. Dr. Miller and I are actually involved in a EVP pathway that is doing that exact thing at our institution. So the label of penicillin allergy is not benign. Patients with penicillin allergy are more likely to be treated with less effective, more toxic, more expensive antibiotics. This can lead to increased cost, antibiotic-associated infections, longer hospital stay, even increased mortality. Cost and simulation model-based economic studies do support that penicillin allergy assessment is a cost-saving intervention. Proactive efforts should be made to delabel patients due to all of these reasons. So when a patient penicillin allergy label is acquired in childhood, these are the implications that can happen. There can have personal health implications, there can have public health implications, and up to 20% of the population is engaged in medical care, is penicillin allergic or has that label that is there. So this speaks to the importance of intervening on this, whether that means delabeling without further testing, doing further testing, etc. for these patients. A recorded penicillin allergy label is associated with 14% increased risk of death. This was reported in a study from 2019. When allergy tested, again, 95% of adults with a recorded penicillin allergy are not allergic. Documented penicillin allergy is associated with increased risk of MRSA and C. diff infections, as well as mediated the increased use of beta-lactam alternative antibiotics. That was in a study in 2018. Risk of cross-reactivity with cephalosporins. So the cross-reactivity has been variably reported depending on the study that you look at. It's been reported as low as 0.1 and as high as 1%. The higher risk could be an overestimation, hard to tell, because the studies have given us such variable results. So a strong consideration of penicillin skin testing can clarify whether there's a beta-lactam allergy, so you're not avoiding the entire class of antibiotics. And this can lead to expansion of the use of cephalosporin antibiotics. So the cross-reactivity, of course, here comes from the beta-lactam chain. We can have, different acyl side chains here, which are similarly cross-reactive between certain penicillins as well as cephalosporins. And then our rings here can differ. And so you could have a potential R2 side chain, depending on the ring and depending on the medication that we're prescribing to the patient. So when we talk about evaluation, if the history is not consistent with an immunologic reaction, you can potentially delabel the patient. Again, check with what your institution is doing to make sure you're doing what's consistent with your institution as well as your allergy staff that you're talking to here, but that is an important measure that is advocated for even in our practice parameters. If the history is consistent with benign, delayed, remote history of a maculopapular eruption, i.e. delayed reaction that is not a severe cutaneous adverse reaction, your specialist can offer direct challenge. If there is a history of anaphylaxis or concern for IgE-mediated reaction, especially a recent reaction, you can offer penicillin skin testing. Now, keep in note, even patients who have a history of anaphylaxis, about 50% are likely to outgrow that particular allergy by 5 years and 80% by 10 years. So there's a role here in skin testing sooner or later for those patients. Clinical data supports direct oral challenges without prior skin testing in low-risk children as well as adults in multiple randomized clinical trials. Skin testing has a 97% negative predictive value, including in individuals with a history of IgE-mediated reaction. For patients histories that are inconsistent, again, no testing generally is required. However, if there is reluctance to the removal of the label or just nervousness in general around that, a single treatment dose can be given to rule out the allergy. In pediatric patients with a history of benign cutaneous reactions, a direct amox challenge without preceding penicillin testing is certainly recommended. Very low risk intervention has been reproduced with multiple studies. For most other patients with a history of penicillin allergy that's remote and benign, again, a direct challenge can be offered. And then I think I've emphasized here that penicillin skin testing is done mainly for a history of anaphylaxis or recent reaction suspected to be IgE mediated.
Recent reaction, how recent?
Yeah,
a year?
I would say within 1 to 2 years, although the definition could be considered within 5 years based on the statistic that I told you as well. Good question. So negative predictive value, I reported it from that one study at 97%, but other studies have even reported a higher negative predictive value. Positive predictive value does drop a little bit. It's about 60%. And then the reagents that we can use include penicillin, this is often referred to as pre-pen, Pen-G, penicilloate, peneloate, and so amoxicillin has now been removed. We do not do skin testing with oral agents. We only do it with agents that can be administered intravenously. But there is some discussion that can be had on the role of ampicillin testing in individuals with a reported amoxicillin allergy. And again, I'm sure that will come up in a future drug allergy lecture. Non-irritating intradermal skin concentrations for cephalosporins and macrolides. So these are reported here, and these can be utilized, again, dependent on your history that has been presented and if you need to proceed with skin testing for those. Similar side chains. So these are groups of beta-lactams that share the side chains. So these are ones that have R1 identical side chains and the antibiotics reported within that, and then R2 identical side chains. I think I have hope I had a chart here that I put in, but I might not have. There are also pretty large charts here that look at individual names of antibiotics that have that cross-reactivity kind of listed out in a little further detail. So you may see those printed and put in your office if you're kind of trying to determine, prescription of an antibiotic or testing of an antibiotic. Okay. So what is the algorithm we follow for cephalosporin administration in patients with a cephalosporin hypersensitivity or a penicillin hypersensitivity? So this is generally kind of what we are recommended to follow. So if there's a history of anaphylaxis with a cephalosporin, so the recommended evaluation for that is going to include cephalosporin skin testing, and then you can have these particular options here. Induction of tolerance procedure, also known as a desensitization or drug challenge, making sure you evaluate the cross-reactivity pretty closely of your cephalosporin. How about if you have a cephalosporin hypersensitivity that's non-anaphylactic in terms of the history? So if there's structurally similar cephalosporin being given, then you follow this route. If there's a structurally dissimilar cephalosporin, then you can go straight to drug challenge here, and then here's other evaluation that can be done. How about cephalosporin administration in a patient with reported penicillin hypersensitivity? So again, it depends on the structural similarity. You can see how important that point is now. And then you go and figure out if the history is consistent with anaphylaxis or not with anaphylaxis. And then you kind of go forward either here with performing penicillin skin testing or going straight to cephalosporin administration. What about sulfonamide antibiotics? Okay, so now we're still talking about generally IgE-mediated reactions. We talked heavily about beta-lactam antibiotics. We're transitioning a little bit now to sulfonamide antibiotics. So sulfonamides are the second most commonly reported allergy in the health record. Most reactions are non-IgE mediated. You can see here that we have a couple of structural related things, the N4 aromatic ring, the sulfonamide structure, as well as the N1 ring that we take into consideration. I know in our board review, we go through this in pretty detail. In any case, so dependent on the drug class, you could have different recommendations on what they can and can't receive. The bottom line here, if the reaction seems very suspicious for a non-IgE mediated reaction, the recommendation is to proceed forward with drug challenge. Drug challenges are the gold standard for diagnosis. It's utilized for when the history demonstrates that there's unlikely to be a drug allergy present. It can be single dose, it can be multi-dose, it can be graded, it can be placebo-controlled as well. So that kind of concludes our discussion on IgE and immediate reactions and evaluation of those. We're going to transition a little bit to non-IgE mediated reactions that can induce anaphylaxis. So I should say we're still kind of talking about immediate reactions, but a different mechanism here. So non-IgE mediated anaphylaxis is largely driven by the MRGPRX2 receptor, or the mast-related G protein coupled receptor member X2 on mast cells. And common offending agents include radiocontrast, opiates, NSAIDs, vancomycin, local anesthetics, because the actual incidence of local anesthetics is very, very low to be reported. Chemotherapeutic agents, and then monoclonal antibodies or other biologics in cancer therapy as well. Now we're going to type 4 reactions. So here we have a higher risk of several type 4 drug allergic reactions ranging from simple xantha to SJS-TEN during generalized viral infections and exacerbation of autoimmune diseases. Disorders in which T cell reactivity is enhanced by widespread immune activations of T cells is something to take into consideration, as well as high cytokine levels, increased expression of MHC, and then co-stimulatory molecules. These are also infections that are no implicators here for us to consider. Maculopapular eruptions are the most common form of delayed drug reactions. They can, of course, arise from those type 4 immunologic reactions that we talked about, but there could be other mechanisms in play. They're typically delayed in onset by at least 48 to 72 hours, or sometimes by multiple days or weeks following the culprit drug. On re-challenge, symptoms may appear within 24 hours. Again, another reason, we do drug challenges the way that we do. All right, so now we're kind of going backwards. We went from type 1 to type 4, now we're going to go to type 3. So type 3 includes one of the most common ones is serum sickness. Of course, Arthus reaction is part of this when you're receiving vaccines or something like that. But in terms of serum sickness with medications, the clinical pieces that constitute a serum sickness reaction can include fever, urticaria or purpuric rash, arthralgia, glomerulonephritis, lymphadenopathy, angioedema as well can be a contributing factor here. Joint pain, joint swelling, that falls under arthralgias. Here, if we have labs that are performed, you could demonstrate a low serum complement level. You could have elevated CRP and ESR. This can begin 1 to 2 weeks after exposure. However, in individuals who've been previously exposed, the symptoms may happen as quickly as a few days. I should say one last point before I transition to SJS. There's no standard diagnostic criteria as of this time in 2025 as it relates to serum sickness. So it's still more of a global clinical diagnosis that we make. Okay. Now transitioning back to type 4 reactions under the category of severe cutaneous adverse reaction. So Stevens-Johnson syndrome is one such reaction. This is characterized by extensive necrosis and detachment of the epidermis. So we have blistering and skin sloughing. We can get mucocutaneous ulcers. We can have various degrees of rashes. And then more importantly, you can have organ involvement, including your pulmonary system, renal, GI, hepatic injury. Mucous membranes are affected in more than 90% of patients. That's why it's such an important clinical piece for us to ask about. If there's less than 10% of your body surface area that's detached, that's SJS. 10 to 30% can be an overlap of SJS-TEN, and then when it's greater than 30% it's TEN. SCORE-10 and ABCD10 are mortality predictors, so you can see these evaluation systems and scoring systems here. They don't necessarily help you with the actual diagnosis of the reaction. So that's assuming that you have a clear diagnosis, and then you're using this as a mortality predictor. All right, DRESS syndrome. So this is another type 4 hypersensitivity reaction. It presents with fever, morbilliform drug rash or drug eruption, facial edema, lymphadenopathy, and generally it happens within 2 to 8 weeks following first initiation of a drug. Lab abnormalities that can occur include eosinophilia, atypical lymphocytosis, involvement of internal organs, hepatitis, nephritis. You can also develop pneumonitis, encephalitis, myocarditis as well. Commonly implicated drugs mirror those seen with SJS, TEN, including aromatic antiepileptics, allopurinol, sulfa, beta-lactam antibiotics, antiretrovirals. Mortality for this one is higher. It's at about 10%. So that's something for us to take into consideration when we're promptly recognizing these patients and intervening on these patients. Relapsing symptoms are confined to one or more organs involved and are common more than 2 weeks after, and then can again coincide with some of these infections here. And then long-term complications of having DRESS syndrome do include autoimmune disease development, development of systemic lupus, type 1 diabetes. So it's recommended that patients have yearly lab monitoring for about 4 years after DRESS syndrome recovery. REGSCAR is an important scoring system that can help determine the probability of having DRESS syndrome. So you take all these factors into consideration, you get a score, and then you kind of use that to determine the likelihood of having DRESS syndrome. Okay, so this is a chart that came from our most recent practice parameters, and there's going to be variable degrees of practices on this depending on your practice. I bring this up because we have done this for a few patients here at Children's Mercy. So in delayed hypersensitivity reactions, the main way that you diagnose these patients is with clinical history, bottom line. However, as you know, there are a lot of situations where your clinical history is confounded by symptoms that are occurring with an illness that sure overlap with that particular hypersensitivity reaction. So it's quite difficult, actually. And so some potential testing measures that can be done, that can be adjunctive, however, include these, which is delayed intradermal testing and then patch testing. However, the negative predictive value and positive predictive value has been reported so variably with these tests across many different studies. It doesn't mean that there's no role. I'm not saying that. I'm not saying that there's not a role, but I'm saying that it has to be done in the right patient. Retest probability should be taken strongly into consideration. Dr. Shopper and I talked about that with one of my patients last week. So in terms of delayed intradermal testing, we inject 0.02 to 0.05 with the patient. If we have any obvious induration that occurs 24 hours after, however, I will report there are reactions that can occur 48 to 72 hours after. So where do we do that? We do that on the volar aspect of the forearm or non-exposed, non-sun exposed area when possible. You do administer a negative control in these patients. There's no positive control. Patch testing is available for different drugs. In terms of the further discussion on patch testing, you're going to have a whole, I'm sure, contact dermatitis lecture where you discuss the details of patch testing. But here in the context of medications, we administer the patch generally on the back. So the site here is going to be recommended generally the flat part of the back. However, the upper arm is alternative, again, a non-sun exposed area. We want to wait at least 6 weeks to 6 months after complete healing from the reaction, 6 months following DRESS syndrome for sure. And then 4 weeks after discontinuation of systemic steroids. And then in terms of criteria for delayed positivity, this is going to be 24 to 72 hours. And then you can have patch removal 48 hours with further meeting up to 96 hours or even 7 days. There's no negative control here. Your positive control can be petrolatum or people. So again, variable negative and positive predictive values. Not all practices for that reason are going to do this, but just know that this is an option that does exist. Okay, how do I diagnose drug allergy? This slide is your takeaway. These are the important questions we should be asking. What's the name of the medication? How long ago did the reaction happen? What systems were involved? When during the course of the medication did the reaction happen? Why was the medication prescribed? Was the patient taking concurrent medications? Therapeutic management secondary from the reaction? Had they had similar medications or cross-reacting medications since? Have they been exposed to same or similar medications since? And has the patient experienced similar symptoms since the reaction? And then does the patient have an underlying condition that favors reactions to certain exposure of medications? Drug desensitization, an important measure that we can take for our patients. The indication for drug desensitization is when you have patients who have had type 1 reactions with anaphylaxis where there is no recommended alternative for the patient. Here we induce temporary tolerance to a drug. We start with generally 1 to 10,000 of the target dose. We double the dose until the desired dose is achieved of the medication. The desensitization is only maintained as long as the drug is continued. So once enough half-lives have passed, the drug is out of the system, it is assumed that the patient has lost their tolerance and they go back to being allergic to the medication. Okay, now we're on our summary slide. Drug allergy is largely a clinical diagnosis. History is an important element aiding in the diagnosis and guiding management of drug allergy. Penicillin skin prick testing has a high negative predictive value, a lower positive predictive value. Delayed drug reactions are common. Uncommon delayed drug reactions can be severe and include scar reactions. There are the references.